My name is Andrea Haller. I am a neurologist with Fort Wayne Neurological Center, and I am the medical director of the stroke service at Lutheran Hospital. So the goals change, but the current recommendations are the same as they have been for quite some time. So IV thrombolytic therapy is FDA approved within the first 3 hours after symptom onset. In some instances, it's up to 4.5 hours, and we do try and give it if we can. The current recommendations are that we try and give thrombolytic therapy within 45 minutes of symptom onset. So the, just a few months ago, or actually 6 or 7 months ago, it was 60 minutes, and that time frame keeps shortening and shortening. So we try very hard to give thrombolytic therapy as quickly as possible because outcomes are better when we do. The interventional procedures are approved up to 24 hours after symptom onset. Again, the goals for when we get this done are shortening and shortening. We try and get patients treated within the first 120 minutes. We know that outcomes are better the faster that patients are treated because time is brain. And as ischemia goes on, as blood flow continues to be inhibited, brain cells die. Well, I think if there's any suspicion at all that the patient might have a large vessel occlusion, they need to be transported just as quickly as possible to a comprehensive stroke center. So rather than bring them to, one of the outlying hospitals, one of our spoke hospitals or those of Parkview, um, to be evaluated first and then transferred over to a comprehensive stroke center where an interventional procedure can be performed, anyone who is suspected to have a large vessel occlusion should immediately go to a comprehensive stroke center. Outcomes. So large vessel occlusion is associated with a 4.5-fold increased risk of neurological disability and death. It is a very big problem. And what we know is that with treatment, people do just a great deal better. So treatment meaning IV thrombolytic therapy, treatment meaning interventional procedures. People who do best are younger. They have lower NIH stroke scales. They're not hyperglycemic. Um, you know, these are all factors that affect the outcome. But the biggest thing is whether or not they get treatment in a timely fashion. So with regard to thrombolytic therapy, IV TPA, alteplase, and now we're starting to use, or we're going to be using tenecteplase as well. With those medications, 35% of patients with anterior circulation large vessel occlusions will actually recover to baseline or near baseline. Their symptoms go away. Of course, we know that about 6% of patients have bleeding complications, and that can result in death or very significant morbidity. And the rest just follow the natural course of, you know, what their stroke history would have been without the TPA. They just don't have a great deal of benefit from it. But we're talking about over a third of patients who could just be normalized by this medication. And then from the standpoint of interventional procedures, they are just tremendously effective. There was a meta-analysis of the 5 studies that was done in 2015, and it showed that in combination, the interventional procedures in combination with the IV thrombolytic therapy, that results in a 50% risk reduction of significant neurologic disability. It takes only 4 patients, so the number needed to treat is 4 patients to have one be free of symptoms. Very exciting. Yeah. We're doing a study here at Lutheran. We're still in the pre-study phases of it, but it should be going to IRB in September, and then in the beginning of October, we will actually be replacing alteplase with tenecteplase. Um, Looking at a retrospective analysis of the last 15 patients who've gotten alteplase and the next 15 patients who have gotten tenecteplase to see their outcomes and the timing of how we do from the standpoint of timing. Because as you probably know, tenecteplase is given as a single bolus. Nurses don't have to be at bedside for an hour with a drip. It's just as easy to use. It's weight based like Alteplase, but it's very easy to use, and it looks like from the data, that has been accrued so far, that it's not inferior to Alteplase. The CVA thing is one of my pet peeves. Now, I know that it's widely used, it's widely accepted, even neurologists use it. I think you've heard me say this before. It's no accident that people have strokes. We don't call them myocardial accidents, right? People have heart attacks, people have brain attacks, but your patients who have strokes have hypertension, diabetes, dyslipidemia, morbid obesity, obstructive sleep apnea, atrial fibrillation, valvular heart disease, etc. It's no surprise sometimes that they've had a stroke. It's certainly not an accident. So, and I think personally, CVA is 3 syllables. It takes longer to say than stroke. And people don't appreciate the urgency of it when you call it an accident. So that's just one of my pet peeves. You can keep calling it a CVA. It's certainly accepted. People know what you're talking about, but that's just one of you'll never hear me say it. So from the standpoint of stroke versus transient ischemic attacks, just one thing about this that I think is important to know, and that is that even in patients whose symptoms resolve, typically within the first half an hour to an hour, even in patients whose symptoms resolve, 35% of them will have evidence of infarction on their MRI. So they have brain damage related to it. That's considered a stroke, but you'd never know it because their symptoms have resolved. We treat TIAs as a neurologic emergency, just like we do stroke. And so patients need to come into the hospital, have the full evaluation, including MRI, echocardiogram, carotid ultrasound, or CTA, or MRI, and be treated as a neurologic emergency. In addition to that, what we know about stroke and TIA is that recurrence, stroke after TIA, the risk of that is highest in the first 7 days, mostly in the first 24 hours. So they need to be admitted. This is a very difficult problem, and the morbidity and mortality from posterior circulation ischemia is enormous. They're harder to recognize for sure. Patients don't come in with, with the kind of classic aphasia, facial droop, although they can have facial droop. Patients come in with more subtle signs sometimes. One of them that really needs to be recognized is fluctuating mental status. They're fine, they're talking, then they're kind of, delirious or near comatose, and then they come back. So that's one thing that I think is really important to recognize. The other thing is that all of the vertigo plus syndromes we have to think about as posterior circulation events. So anyone who comes in and they have the acute onset of spinning sensations, let's go back and just say vertigo is not just spinning. Vertigo is any sensation of movement. So a rapid onset of like a sensation like you're on a rocking boat, or that you're moving in a room, but the room is not moving, or a room is moving around you, but you're still. All of those things are vertigo. So when vertigo is associated with any other focal neurological sign or symptom, we need to be very concerned about the possibility of a posterior circulation stroke. So vertigo plus, the patient saying that their eyes feel like they won't stay still, or you look at them and their eyes are bouncing around. Patients, saying that they have, vertigo plus for some reason it's difficult for them to swallow. They started drooling. That suggests, hypopharyngeal or pharyngeal dysfunction, tongue dysfunction, very important. And then of course we see patients with the kind of symptoms that we would expect with an anterior circulation stroke, unilateral weakness, sensory abnormalities. The key on that is that if the patient says, I'm not sure, my right face feels totally numb, but my left body feels numb. So crossed sensory abnormalities is another thing that we see. These are difficult things to assess in the pre-hospital setting, but again, vertigo plus anything else is important to think about posterior circulation stroke. So I will also mention that, from the standpoint of posterior circulation strokes, the posterior circulation is a smaller circulation than the anterior circulation, but it's the circulation that allows us to stay alive, right? So it's the blood vessels in the posterior circulation keep us breathing, keep our eyes moving, keep us swallowing, keep us conscious. And so, yeah, we've missed them in the past. There's no question. There's no question about it. Um, but we shouldn't be missing them. We have less data on the best ways to treat them. All of these studies with the interventional procedures were done with the anterior circulation only, but we do treat posterior circulation strokes because of how high the morbidity and mortality is for these strokes. And I will say, the NIH stroke scale, which I use all the time, all the time, and then FAST, those are great tools, but they don't assess the posterior circulation. Um, and and so you have to have a high clinical, an index of suspicion, a high clinical index of suspicion to kind of come up with this. FAST is a great tool. Be fast, involving balance and eyes. That's a better tool. You don't actually have to do anything with it. You just have to ask, are you having any problems with your walking? Any problems with imbalance? Have you noticed any symptoms in your eyes? Have your eyes been, batting around? Do you have double vision? Is your vision blurred? Because those things give you clues that FAST doesn't. And so I think it's, we don't have to, in the pre-hospital setting, we don't have to use a new tool. We just have to ask 2 questions. Are you having trouble with your gait, your balance? Are you having any symptoms with your eyes? And that can really, really help. So I think that that's just something to kind of keep at the back of your head. One important thing to know about these strokes is that 87% of strokes are ischemic, so caused by occlusion or decreased blood flow to a certain area of the brain. But there's another 15% of strokes that are hemorrhagic, and hemorrhages cause more morbidity and mortality if that's conceivable. So they're very important. What can happen is, there are a number of reasons why people have intracerebral hemorrhages. There are subarachnoid hemorrhages, which is part of this population, that's 15%, that can be caused by aneurysms that rupture. There are non-aneurysmal subarachnoid hemorrhages, and there are just intracerebral hemorrhages, parenchymal hemorrhages, right into the brain tissue itself. An exceedingly common cause of that, the most common cause, is hypertension. And of course, hypertension is a risk factor for both. We do evaluate patients with hemorrhagic strokes in a similar way to patients with ischemic strokes. They get MRIs, they get echocardiograms. We look for embolic sources because, of course, some of these hemorrhages, and you can't tell necessarily immediately, some of these hemorrhages are bleeding. They're called hemorrhagic transformation of an ischemic stroke. When people have an ischemic stroke, it's not just brain that's damaged, it's all of the tissues. So the blood vessels in the area are damaged, they become friable and are more leaky and likely to bleed. And so we do see that. Age, size of the stroke, blood pressure, those are all associated with the potential transformation to a hemorrhage. But then other times people just hemorrhage, and like I said, hypertension is a big risk factor for that. One of the major differences that with regard to treatment of the two are the blood pressure parameters that are set after a stroke. The brain is fabulous. I mean, it's really, I'm sitting here because doing what I do because I think the brain is fabulous. It's just an amazing organ. It can regulate its own blood pressure, its own blood vessels. The brain can cause dilation or constriction of its own blood vessels. The rest of it, there's no other organ that can do that. But that becomes disrupted in the setting of a stroke, and so the brain can't regulate its blood flow. And so after an ischemic stroke, we let blood pressures go high, not only because the autoregulation of cerebral blood flow is disrupted, but also because the brain swells just like any other part of the body that's injured. And so you need a higher pressure stream to get blood flow into a damaged area. So in ischemic stroke, in the absence of any cardiac disease, so let's say, we'll ignore the circumstance in which people have heart attacks and then have a stroke because of it. In normal circumstances, we let blood pressures, go up high. We call that permissive hypertension. And so the recommendations are don't treat blood pressure unless the blood pressure is greater than 220 over 120. That seems really, really high. I know it does. And oftentimes practitioners are uncomfortable with that degree of blood pressure. And so we kind of see people cutting it off at 200 over 100. But the problem is that when you lower blood pressure acutely and significantly in the acute stroke setting, you don't get blood flow to the brain, and areas of the brain that are ischemic, meaning that they've suffered with loss of oxygen and glucose. When they're ischemic and you lower the blood pressure and they don't get blood flow, they infarct, they die. So we can see people doing really well, and then all of a sudden they're given, their blood pressure medications that they were taking at home, and their blood pressure drops to 120 as it's intended to do, and they have neurologic worsening. From the standpoint of hemorrhages, we're a little more ginger in the treatment of blood pressure. We treat for blood pressures typically greater than 140 because of the risk of increasing the hemorrhage size. So that's one of the major differences. And in addition, these people can be sicker, meaning they may not be fully conscious. They might, because it causes a lot of swelling. They might not be fully conscious. They might not be able to protect their airway. They're often almost always in the ICU. Well, the simple answer to that is no. It doesn't matter to me whether it's at the right side of the brain or the left side of the brain. The workup is the same. The treatment is the same. It can certainly affect which side of the brain can certainly affect a patient's quality of life, but all large vessel occlusions, and even to a certain extent, small vessel strokes, not to a certain extent, small vessel strokes will also affect a person's life. There are some symptoms and signs that are similar between the two hemispheres. There are some that are quite different. So you can have visual disruption. We call it a homonymous hemianopsia. Either side. That's one sign of a large vessel occlusion. In a left hemispheric stroke, people will lose the right side of their vision in both eyes, and the opposite is true on the right. They'll lose the left side of their vision in both eyes. That's one of the things that we look for. From the standpoint of, and I'm sure all of you know this, from the standpoint of a left hemispheric stroke, aphasia is a very common symptom and sign that we see. And then, of course, the opposite hemiparesis, hemisensory loss. So aphasia and homonymous hemianopsia on the left. On the right, what we see oftentimes is severe neglect. You can have neglect in a left hemispheric stroke, but you would be neglecting the right side of the body. The right hemispheric strokes, people have profound neglect. They don't even know they have a left side of the body. So, you do this, whose hand is this? You hold the patient's hand above their face and they say, your hand. Like, of course it's your hand, moron. They don't even know that they have a hand, which really impacts their ability to rehab. So that's one of the key differences we see. Aphasia, I will tell you, affects a person's ability to rehab also, because what normally comes back first as people are recovering from stroke is the ability to understand. But the ability to produce language, to speak, and of course this means to write and to read, that it takes a long time to come back, and people can become severely depressed. And of course it's the depression that affects the rehab rather than the aphasia itself. So we use both. Of course, the blood pressures that we don't want to lower blood pressure acutely. We don't want to lower it a lot acutely. We need, if patients are considered potential IV thrombolytic candidates, we need their blood pressures to be 185 over 105 or less. But we generally don't want it to be 120 over 60 or 100 over 60. That's dangerous for stroke. Um, we can't use thrombolytic therapy when people are consistently in the 200s over 110s, because it increases the risk of bleeding. And in those instances, we often use either labetalol or nicardipine. So the labetalol is excellent to use. It's short acting, has rapid onset of action, but it lasts for this long, like 5 to 10 minutes. So, and then of course, if the patient has any problems with bradycardia or any bradyarrhythmias, it's going to lower the heart rate also. And of course, lowering the heart rate can lower cerebral perfusion. So we just have the heart rate issue is one to keep in mind. So labetalol is often the first choice. 5 milligrams, 10 milligrams of IV labetalol. Watch what the blood pressures do. If it shoots right back up to 200, 220, or 120, and you want to give TPA, you can give it again, but blood pressures have to be in the appropriate range for thrombolytic therapy for a consistent period of time before that medication can be given. So, and that's where cardine comes and nicardipine comes in. It has it's usually a drip. We don't just give it dose after dose after dose, and it also has a fairly rapid onset of action, but it lasts longer. And of course, you're giving it as a drip. I will note that there is, unless it's monitored carefully, there is a danger because it's a drip of lowering blood pressures too significantly, but it usually gives a smoother blood pressure, smoother blood pressures over time in ranges that we can use thrombolytic therapy. I wouldn't not use labetalol, but I certainly wouldn't give more than a couple of doses every 10 minutes. Before I would start something different if I wanted to give thrombolytic therapy. Looking for new ways to treat stroke for a long time. I think the biggest thing that's happened over the last 5 years is, of course, the interventional procedures, which are changing all the time. So there's now mechanical thrombectomy. They're placing stents. I think the use of stents will be more and more commonplace over time. I think people will be doing it in the posterior circulation more. So that endovascular treatment is going to continue to be extremely important. Researchers have been looking for neuroprotective agents forever. There was way back when I was just out of training in the early 2000s. There were reports that guaifenesin was neuroprotective, NMDA antagonist, and so I had a bottle of cough syrup in my in my medicine cabinet at all times. Don't use this until, but we don't have a neuroprotective agent now, and I think that in the next 5-10 years we will likely consider the speed at which things have been changing in the last 10 years. I suspect that we will have neuroprotective agents that can be given pre-hospital. So you think the patient has a stroke, give them a neuroprotective agent. Hopefully that will improve their outcomes. That's really the goal. There are a lot of new rehab techniques and research on agents that improve outcomes for stroke that improve neuroplasticity and things like that. So that's on the horizon as well. But I think that it's an exciting time. It's an exciting time to be a neurologist. We have all kinds of new treatments for lots of different things. It may be the case that there will be genetic therapies, antibody therapy, monoclonal antibody therapies. I'm not 100% certain what's going to be, what will be happening first, but I am certain that before I retire, we will be doing a great deal better from the standpoint of stroke. Honestly, we should also be doing a great deal better from the standpoint of preventing stroke, risk factor modification, lifestyle changes, etc. Okay, so what we know about COVID and stroke is that in about we'll say 2, but it's like 1.8% of COVID positive patients we see stroke. It's more often in younger people with more severe stroke syndromes, and it's probably related to hypercoagulability or blood vessel inflammation. Um, but it's not every patient who has a stroke. I know at Lutheran we are COVID testing every patient with stroke, um, but um, but young people with in this particular time, young people with strokes, um, that's something to consider.
If you had one point to drive home, what would that be?
Think of stroke, consider it an emergency, get people to the hospital.